Good morning. Let me thank the Kandy Society of Medicine for organizing this workshop, especially Dr. Samanna Nayakkara and Dr. Krishna Pradeep, along with consultant nutrition physician Dr. Yvonne Javira. KSM, of course, is like a second home to me. So I've given so many lectures here, and it's good to see people like Charles and IRC. See Sunishka also here, Dr. Chaminda Kolaratna. So a lot of familiar faces. So good to see you. Just going back about this collaborative workshop. As Dr. Samanna Nayakkar said, or I'm sorry, Professor Samanna Nayakkar said, the two premier professional organizations dealing with nutrition in Sri Lanka are the Sri Lanka College of Nutrition Physicians and the Sri Lanka Medical Nutrition Association. So both the presidents are here. So now you know that in the future, if you want to contact anyone with regards to nutrition, these are the two societies to contact. So I hope you will network after this. So I think you already got a sneak peek of my next slide. So just to get the curiosity. Now this is to show you the different men's grooming techniques over the years. So you can see Elvis Presley, and then when you were little you looked at Robin Hood, and then that's David Beckham, I believe, and Virat Kohli. So you can see during different times there are different trends, different styles. So similarly in the diets also there are different trends. So some time back, everybody was asking me about the keto diet. Now they are asking about the intermittent fasting. So that is supposed to be the trend nowadays. But actually, the trend has changed now, at least in US. So I hope you know who this is. So this is Elon Musk, right? And you can see he has lost a lot of weight. You can argue that it is because the share price of Twitter has gone down, but I don't think that is the case. So if you don't know him, I'm sure you know this person, right? So you can see, so all these celebrities are losing weight. So now you know that there's something going on. So what is the latest trend now? So this is the weight loss drug, liraglutide, okay, and under the brand name of I think Ozempic, which is used for treatment of diabetes, but people are using off-label. And there is a licensed drug for weight loss also, liraglutide high dose. It's called Wegovy. But we don't have this here. So you can see these trends are changing. Okay. So if you look at obesity, so here you can see in 2017, American Medical Association recognized obesity as a disease. So there is a paradigm shift in the management of patients with obesity. So now we recognize obesity as a disease. So obesity is not a disease of sloth and gluttony. So in other words, people don't gain weight because they don't have self-control. So we should not blame people for gaining weight and also not losing weight. So that is one aspect of it. And the second thing is, if obesity is a disease, you might ask whether there are any functional or structural changes that leads to this disease. And in fact, now we do know that there are some irreversible changes that happens in the patients with obesity. Now this is a paper that came out I think last month or a couple of months ago. So here you can see the brain responses to nutrients are severely impaired and not reversed by weight loss in humans with obesity. Okay, so that further confirms that obesity indeed is a chronic disease. So in this context, what I'm going to discuss in the next 20 minutes or so is, first we will look at obesity as a disease, and then what are the management tools, and then very importantly the different phases of weight loss interventions, and then the major part will be the dietary approaches for weight loss, and then we will touch on the latest trend, the intermittent fasting, and then we will talk about weight loss maintenance. So we know that obesity means having excessive fat, which will lead to impairments of health. And in terms of diagnosing obesity, now this is from Dr. Noel Somasundaram's Colombo urban study. So in this study we found that in urban Colombo, the prevalence of abdominal obesity in adults was a staggering 58%. So this is much higher than the ones we thought earlier. So it's a big problem in Sri Lanka. So we know the BMI cutoffs. Again, we use fairly lower BMI cutoffs for Sri Lankans. The cutoffs for childhood obesity are different, and I don't know whether Professor Pujit Vikram Singh will touch on that. So he's the foremost authority on childhood nutrition and pediatric obesity in Sri Lanka. So I hope he will maybe touch on this. So now coming back into this concept of obesity as a chronic disease. So if obesity is a chronic disease, you have to manage it as you manage other diseases. So for example, you have to think about primordial prevention, and then primary prevention, secondary and tertiary prevention. So it's a paradigm shift. So if obesity is a chronic disease, it requires long-term, probably lifelong treatment, right? So now let's say, for example, if someone does a fasting blood glucose and you find it's very high, so the next step will not be searching the internet for treatments to reduce blood sugar. No, you probably talk to Dr. Charles and Tiruvil, right? So similarly, because you're not going to treat diabetes for about a month or two and then forget about it. No, so it's a lifelong treatment. So similarly, if someone is having obesity, you have to go for long-term, probably lifelong treatment. Now, in terms of managing patients with obesity, weight loss definitely is part of it. And how much weight loss is necessary? Around 10%. So for most of the comorbidities of obesity, like metabolic problems, non-alcoholic fatty liver disease, certain mechanical problems, like osteoarthritis of the knees, 10% is the target that we set. Now we still see doctors, giving their patients a weight loss target of 20-30%. Some patients come and say, the doctor asked me to reduce 30 kilos, otherwise he will not do the surgery. So that is not practically feasible, and also if you look at the evidence, it is not necessary. So 10% weight loss is the one we target in generally to achieve in 3 months. So you can target 3 to 6 months. That's all right. So you can see for most of the comorbidities, even for sleep apnea, around 10%. But of course, if you go for 15%, it's even better. For things like diabetes remission, you might have to go for about 15% weight loss. But 10% is a number you have to remember. So what are the obesity management tools? So we can show it as a pyramid. So the cornerstone or the base, the foundation is lifestyle modification, which comprises of dietary changes and changes in physical behavior, physical activity. And then pharmacotherapy has come to the forefront fairly recently with the emergence of these new anti-obesity medications. Surgery, of course, we know bariatric surgery is extremely effective, but it is only suitable and also feasible for a very minority of patients. So when you talk about lifestyle modification, it has 3 components. So first one is you have to make some dietary change, which boils down to reducing the energy intake, caloric restriction. And then on the other hand, you have the increase in physical activity. Now, the third part is what is called behavior therapy, which is actually based on some psychological techniques which you can employ to achieve these 2 previously mentioned targets. Now, in fact, if you look at the NICE guideline, okay, if you look at the NICE guideline, they define lifestyle modification based on the behavior change. So they say it is behavior change strategies to increase physical activity, decrease inactivity, improve eating behavior and quality of diet, and also reduce energy intake. So not the number one is not the reduce energy intake. Okay. So if you look at all these different diets, keto diet and intermittent fasting, all that, you are targeting only the reducing energy intake. Okay. So the next time you are going to ask me or any nutrition physician, what do you think about the intermittent fasting? You have to ask yourself the question, will you be able to do intermittent fasting for the rest of your life? Will you be able to do the keto diet for the rest of your life? Because if you follow these diets, for a short term, if you search the internet, some time back I came across a diet called the Hollywood cookie diet. You are only allowed to eat cookies. Very heavy, I mean, you can eat any cookie. But can you eat like cookies throughout the day? No. So you lose weight because you are not taking enough calories. But after some time, you give it up and you regain the weight. Okay. So that is what I want you to understand. So now when we talk about the dietary strategies to reduce energy intake, we have different tools available. Okay. Now remember, behavior modification is incorporated into all these strategies. Okay. So one of the most effective ways of reducing weight for a short period, over a short period of time, is going for what is called a very low calorie diet, or a VLED, or a very low VLCD. So by definition, this is a diet where you take less than 800 calories per day. So now if you compare this with, say, an average male, Sri Lankan male, probably it's about 1800 calories, not 2000. We think you need 2000, probably 1800. A Sri Lankan female, probably 1600 to 700. Okay, so compared to that, 800 it's a very low calorie diet. Okay. Then of course, bulk of the different diets are what are called reduced energy diets, by definition less than 1200 calories per day. And then of course you have these so-called ketogenic diets, which are low carbohydrate diets. And then you have the intermittent fasting. And of course the other one is the different types of dietary patterns. For example, following the Mediterranean diet or the DASH eating pattern. So in terms of long-term adherence, these dietary patterns are much easier to follow. Okay. So in fact, you will understand that at the end of the day, these are the types of things that we recommend also. Alright, changing the eating pattern, following a healthy eating pattern. Now, you have to realize that weight loss doesn't occur like on a straight line. Now this happens. Now sometimes when you give patients a lifestyle modification program and you meet them in 1 month and they are very happy because they have lost a lot of weight. But when they come the next time, they say, I didn't lose the same amount of weight, which is normal, which is physiological. Because when you lose weight, your basal metabolic rate also decreases. Alright. So therefore, it's a curve like that. Initially, you lose a lot of weight and then it sort of tapers off. But remember, most of the weight loss trials and us, for example, we focus only on the active stage, the first stage, okay, which probably lasts for about 3 months, 6 months, maximum 1 year. So if you look at all the trials, that is the length they have gone to, mostly 3 months or 6 months. But then if you do any of these diets, like say keto diet or intermittent fasting or very low calorie diet, whatever, after about 3 months you have to go for reintroducing your normal food. And then in the maintenance stage, that is the most important phase, because weight loss is easy, weight maintenance is the challenge. Okay, so therefore this what is not shown here is the weight regain phase, which occurs afterwards, and probably it will come to the baseline in about 2-3 years. Okay, unless you do lifelong dietary change and behavior change. Now, if you talk a little bit about the very low calorie diets, as I said earlier, they are very effective for the initial induction of weight loss phase, And here now remember, we can't do a very low calorie diet on regular food. So here you have to do either total diet replacement or meal replacements, which come in the form of shakes or sometimes bars, soups and things. So sometimes you can give all 3 meals as these pre-prepared foods, or else in my experience, we generally give, maybe we replace 2 meals a day and have 1 meal which is fairly low in carbohydrates, high in fruit, vegetables and protein. Okay. Now these meal replacements have been used, this method has been used in a lot of trials, and the most significant trial would be the direct trial, where they showed that if you use these meal replacements, at the end of year 1, close to 50% of people with diabetes can go into remission. That is, they are off drugs, they are off the anti-diabetic drugs. They are not cured of diabetes, but they are in remission. And you can see even after year 2, it's a significant proportion of patients were in diabetes remission. So this is a very effective technique. So if you look at the reduced energy diets, here the key is, don't worry too much about the graph. The key I want to show here is that as long as a diet achieves energy restriction, they will be effective in bringing about weight loss. Okay, so you can't argue that keto diet is superior to low fat diet, so whatever. All, if you do it now, but remember, all these are evidence based. So keto diet has a lot of good evidence. Intermittent fasting also has good evidence, but none is superior to the other from the short term. Long term, we don't know. Okay, but again, if you ask that question, can I do this for the rest of my life? Probably not. Then I will talk a little bit more about intermittent fasting, because that is the one people ask a lot during the last few months. So here it's a different approach. So instead of restricting the types of food, you restrict the time. So this is called time restricted eating. So you can do it in 2 different ways. So some people do this what is called 16-8. So they eat only 8 hours during the day. For the rest of the 16 hours, they don't eat anything. So during that 8 hours, they eat whatever they want. Then other method is, you can do either alternate day fasting or the 5-2. So in about 2 days, you do a really rigorous fast, but other 5 days you pretty much eat normal. Okay. So again, there are a lot of evidence on this. So in fact, even New England Journal of Medicine, they published this review paper, about intermittent fasting, right? But at the end of the day, if you look at all the literature, what do they say? Intermittent fasting is not superior to other eating patterns. Okay. So if you look at the keywords, they did not produce, it's not more effective than the others. Okay. So it's effective provided you do it the correct way in the short term, but it's not superior to the others. But then if you look at what the professional organizations say, right now, before that, another meta-analysis. Here you can see only one significant association supported by high quality evidence. 1% of all the trials they looked at. Okay. So what do the professional organizations say? If you look at the American Academy of Nutrition and Dietetics, they say that intermittent fasting is not currently a recommended treatment for weight loss or any other health condition. And moreover, they say it may pose a health risk for certain individuals, especially with people with diabetes, right? And women who are pregnant or breastfeeding, and individuals with eating disorders and disordered eating. Fatty liver, I don't know. So probably, if you ask me, I personally would not recommend it. But you can do it in the short term, provided you do it in the correct way. But I would not recommend it based on the recommendations of the professional organizations. So what are some of the other eating patterns? Now this is the Mediterranean diet. So I'm not going to go into details about this. Okay. So Mediterranean diet, here you can see remission of diabetes by the Mediterranean diet. So you can see at the end of 1 year, about 15% of people who followed the Mediterranean diet went into diabetes remission, which gradually, the number reduced over time. Okay, sorry about that. So in terms of eating patterns, what we recommend for Sri Lankans is this plate method, which is based on our, the food that we eat. That's mainly we have rice based there. So this is what we recommend, and I am really glad to say that the Ministry of Health has actually adopted this. Some time back, the Sri Lanka College of Physicians made guidelines for different chronic diseases. So I was involved in the guideline for management of hypertension as well as diabetes, and so both the what we proposed was this plate method, and it's actually, if you look at this guideline, it's very nicely there, and in the supplement, the appendix, you have a different dietary advice for these two conditions. So here we have used the plate method. So as you can see, half the plate should be filled with non-starchy vegetables. We cut down the amount of rice, so only quarter of the plate, and then the other protein, the protein food, it's very important, should be the other quarter. So it does not necessarily have to be foods of animal origin. You can even go for pulses like dal, cowpea, kadala, green gram, soy, and so on for that quarter also. But at the same time, when you want to make behavior change, you have to change the way that we cook. So for example, instead of deep frying food or adding a lot of coconut milk, polkiri, we can go for cooking techniques like boiling, then steaming, grilling, and then cook with spices, what you call in Sinhala as mirisata, without coconut milk. It's very tasty. Or you can use a little bit of oil to stir fry things. Okay, so you change the behavior. So once you change the behavior, you can do it for the rest of your life. Okay, so eating, the cooking techniques are very important. And then things like avoiding sugar sweetened beverages. Okay, so things I have highlighted here. And especially, as I mentioned earlier, if you want to lose weight and maintain in the long run, behavior change is important. So behavior therapy is important. So one of the concepts is stimulus control. Okay, so if you say, if I see chocolate, I want to eat it, don't keep chocolate at home. Simple. Okay, of course, I don't know what to do when this Chumpang guy comes. Probably you'll have to threaten him, and so again, that is a stimulus. When you hear that, you go and buy it. Okay, so to control the behavior, you have to remove the stimulus. Okay, and then assertiveness. If somebody offers you something, you should learn how to say no. If they offer you a piece of cake, say, sorry, I don't eat cake. Don't say, I'm trying to lose weight. You say, I don't eat cake. So that's, I think, a technique they use for smokers also. They say not to say, I'm trying to quit. They say, I don't smoke. Okay, so you're already in that behavior. Okay, and the other things, this sharing food is a big problem. Okay, and then also social support is extremely important. Because we get all these negative comments. Why are you eating? Aren't you on a diet? It's not healthy. Okay, then all these things, and especially in our context. Now I got this from the internet. So social and family support is very important, right? So sorry about the grammar, but I got this from the internet. So they say this is not fit. So they like the one on the right side, because that is the image we have, especially parents and sometimes the spouse. So they don't like the others losing weight, and they say, are you sick or something? So these things we have to learn how to overcome and get over. And also positive reinforcement is called operant reinforcement. If you do something, you have to reward yourself. That is how you build good habits. Okay, always reward. So people say, I don't have time to go on the treadmill, right? Now if you like to watch a movie, if you love watching movies, you have a rule, say, I only watch the movie when I go on the treadmill. Okay, so then you look forward to going on the treadmill. So things like that. Okay, if it's a child, it's following everything, you reward by buying a bicycle. So they will, rather than just blaming him, saying, why don't you go outside, and play, you buy them a bicycle. And then physical activity is extremely important. So try to minimize sedentary time, seated time, and then at least try to aim for moderate intensity physical activity like brisk walking, 30 minutes a day, 5 days a week. Of course, if you want to go further, you can double that. And strength training is also very important. So ladies and gentlemen, in summary, the most important thing I want you to remember is that obesity is a chronic disease which requires long-term, probably lifelong treatment. Aim to achieve about 10% weight loss for a therapeutic benefit, and lifestyle modification is essential. Energy restriction via any diet will achieve weight loss, whereas intermittent fasting is not superior to other weight loss methods. And remember, every weight loss program should be transitioned into a probably lifelong weight loss maintenance program. Thank you very much, and I think we have about 3-4 minutes for questions.
Thank you so much for that excellent presentation. When it comes to using these different dietary patterns, can't we use one particular dietary pattern for weight reduction and another one for weight maintenance? Because what I've seen among young people is when it comes to intermittent fasting, they do it religiously and they lose a lot of weight. So later on, if you can switch to some other method to maintain that weight, would it be a proven?
Yeah, so that's an excellent point. In fact, that is what I mentioned also. So for the weight loss induction phase, you can use these different methods. As I showed you, all these are effective. So you can tailor made, customize a particular program. Now, as you said, if intermittent fasting works for somebody, go for it. If the keto diet works for it, go for it. Provided it's the correct way. But after about 3 months or 6 months, then, as you said, you have to switch on to a regular eating pattern with behavior modification. Otherwise, they will regain this weight in about a year. That's an excellent point. Yes. Yes.
I recently read an article that they say it's not what you eat, but when you eat. So they are also emphasizing on the timing of it. It's not about the prolonged fasting, but the time you have your dinner, time you have breakfast. Is there any evidence on that? It's just an article that I read. So what's your impression on that?
So again, so this the when you eat means, so it's again they are talking about the intermittent fasting and that sort of pattern, and also whether avoiding breakfast and things. Now, what research has shown is that for adults, even if you miss a meal, it's not a problem, provided you eat, you have the same amount of calories. But for children, studies have shown that children who do not eat breakfast tend to gain weight over time. In fact, they can be malnourished as well as undernourished as well as overnourished. So breakfast is essential, especially for children. So what I would recommend is, go for the 3 meals, and probably if you want to go for snacks, go for healthy snacks like fruits. And now these articles you mentioned, now you see all these things in the internet, sometimes based on cellular studies or animal studies. Now if you take this intermittent fasting, sometimes I saw that they link it to this process called autophagy. And autophagy is like digestion, self-digestion inside the organelles. And they have shown that autophagy, if you knock down certain genes in mice, they live longer. So now they come out and say intermittent fasting, you get more autophagy, you live longer. So you have to sort of look at the literature really carefully. I think time is up now. Okay, thank you very much.
Thank you very much, sir, for that enlightening and timely update. We shall now move on to the second session of the day, which will be an overview on artificial nutrition. The first speaker for this session will be Dr. Nalinda Hera, who is a consultant nutrition physician at the National Hospital of Sri Lanka. He will be discussing on enteral nutrition. There will be 10 minutes. There will be 10 minutes allocated for question and answering session at the end of the session as well. Over to you, sir.
Very good morning. So, I'm going to talk about enteral nutrition. It's a clinical topic. So, during the lecture, I'm going to talk about the why this nutrition therapy is important in the clinical setup, and what is the process, and when this is given, and what kind of enteral nutrition we provide, and how it is given. And at the same time, I'm going to discuss about complications of enteral feeding. So, why nutrition support is needed in hospital setup? As you well aware, during an illness, your oral intake will automatically reduce due to various reasons, maybe oral conditions, taste, dysphagia, strictures or impaired absorption, or diarrhea. So, on the other hand, the energy requirement, nutritional requirements are very high due to fever and due to stress hormone activity and other metabolic reasons. So, as a result, negative energy balance occurs. So, due to this negative energy balance, malnutrition occurs. So, it is reported that nearly 40% of hospitalized patients are malnourished, right? So, when you are malnourished, your morbidity is high and wound healing will reduce, and more infections rate, more complications, and it will take more time to recover from the illness. Finally, mortality will high, and length of hospital stay will prolong. As a result, hospital expenditure and quality of life, everything is affected. So, what is the clinical nutrition care process? So, first step is malnutrition risk screening. Actually, this is done by this can be done by even by a non-medical person. If you train properly, this nutrition screening can be done. There are various tools. I will elaborate regarding the nutrition screening tools during my next few slides. And then we do the nutrition assessment. Usually, the screening part is done by the ward staff or other clinical specialties. So, then you refer the patient to the medical nutrition unit in the hospital. Then we do nutrition assessment. Nutrition assessment also we have several steps. I will elaborate later on. And then we come to a nutrition diagnosis. Then we do the medical nutrition therapy. This medical nutrition therapy is not complete if we don't monitor properly
and evaluate, then we have to follow up this patient properly. Now, regarding nutrition screening, there are various tools. This MUSTIS malnutrition universal screening tool. If you Google, you can get more details. NRS 2002, this is validated for ICU setup. Nutrition risk score 2002, this is validated for critical care setup. And mini nutritional assessment MNA and subjective global assessment. So even though there are many tools, the practical way most of you follow in your ward setup is measuring weight and calculating the BMI. Then how do you, the second step is nutrition assessment. When you refer this patient to our nutrition clinic, we follow ABCD. This anthropometry is, weight, height, and then we calculate BMI and maybe waist circumference. Then biochemical, most of sodium, potassium, and albumin level. A lot of biochemical, laboratory parameters. Then clinical, of course, as medical people, all of you know, general examination from head to toe, features of micronutrient deficiencies, quality of hair, skin, whether dry scale is skin or not, right? And palo, angular stomatitis, glossitis, like that. You identify various, the most important thing is muscle wasting. The degree of muscle wasting is very important. Then dietary. Dietary, of course, this is done by the history. Whether patient has lost his appetite significantly and he has reduced his oral intake significantly during last 1 week. Those are important information. So using this information, which we gathered from the nutrition assessment, then we come to the nutrition diagnosis. For the diagnosis, we use, this is the accepted criteria, this is GLIM criteria. So if you see the GLIM criteria, there are two types of major criteria, phenotype criteria and etiology criteria. Under phenotype criteria, you can see weight loss, body mass, muscle mass. So those are the factors we consider. Under etiology criteria, we consider food intake and disease burden. So depending on this criteria, we can diagnose whether this patient is moderately malnourished or severely malnourished. So depending on the degree of malnutrition, we do the relevant or particular nutrition management. So for the nutrition care or nutrition forms of products of nutrition care therapy in the hospital, even without the nutrition team involvement, this meal environment, hospital diet is provided by the hospital kitchen. So meal support, eating support, all these are nutritional interventions. And if you consider the diet, regular hospital diet is there, therapeutic diets are there. Then if you come to proper medical nutrition therapy, we can divide into three, maybe oral nutrition supplements or enteral nutrition support and parenteral nutrition support. So palliative nutrition also most of you do in your clinical setup for the relevant patient in your ward, maybe IV drip or like that. So I'm going to discuss about this enteral nutrition part. Very basic concept regarding enteral nutrition, which is important for the clinical setup. So enteral tube feeding. So if you tell, if I mention as enteral nutrition, you get the feeling of even this oral nutrition is having normal meal also some kind of enteral nutrition, isn't it? Right? But in nutrition subject, we refer to tube feeding. Enteral nutrition means tube feeding, right? So nutrition therapy given via a tube or stoma into the intestinal tract distal to the oral cavity. So this is the definition of enteral nutrition in the clinical nutrition subject. So total enteral nutrition means all nutrition needs are provided through a feeding tube without significant oral or parenteral intake. So at the same time, we can do supplemental enteral tube feeding. So nutrition is given to patients whose oral intake of food and fluid is inadequate for reaching their defined target alone. Right? And you can do home enteral nutrition as well. So when it is done, at least 50% of energy requirement is not achieved by oral route in 5 to 7 days or expected to be not achieved in next 5 to 7 days. So this is the time we initiate enteral nutrition support. Or inadequate or unsafe oral intake with a functional, accessible gastrointestinal tract. Right. So ideally, nutrition support should be commenced within the first 24 hours of admission. So this is the recommendation. Right. What are the contraindications for enteral nutrition? In which conditions we do not provide enteral nutrition? Failure of intestinal function, complete intestinal obstruction, anastomach leak or absence of intestinal integrity, high output intestinal fistula where feeding not possible beyond the fistula, and shock of any origin, hemodynamic instability, metabolic instability, and ethical considerations like in palliative care or maybe in terminal care. Right. Why is enteral feeding preferred, or what are the benefits of enteral feeding? It maintains the GI tract functions and integrity, and it stimulates GI contractility, and it supports gut and mucosal associated lymphoid tissues, which is called, then preserves gut microbiota, and it prevents parenteral nutrition associated infective and metabolic morbidities. So if the gut works, use it. So if you talk about gut barrier, we can divide into two: physical barrier and functional barrier. So physical barrier includes gut microbiota, intestinal mucus, epithelial cells. This functional barrier includes gut associated lymphoid tissue, which is called GALT. So those are so all these gut barrier can be properly maintained by providing enteral nutrition. So that is the benefit of enteral nutrition. Sometimes you have seen in ICU setup, even though you cannot start proper nutrition, at least you have to provide at least a tropic feed as soon as possible. So enteral access devices, we can, for the short term we use NG or NJ. If you go for long term, ideally, if it is more than 4 weeks, you have to consider PEG or PEG. So this illustrates various kind of tube feeding. NG tube all of you have seen. So types of gastrostomy tubes. So long tubes are there, and this the single one is a button type, which is cosmetically very important for small children when they go. I mean, if they attend school, they can't go there with a long tube. So it's important to have this button type of gastrostomy tube. So what to give enterally? So these are the different kinds of enteral nutrition preparations. You can divide polymeric, oligomeric, disease specific, and other kind of feeds. So most of the time we use blenderized food in your ICU setup or in the ward setup or in the home setup. We have seen until we provide proper proper medical nutrition therapy. So Ben rice meals, we used to give rice kanji soup, which is nutritionally not optimized, right? Previously, people use even orange juice and raw eggs, right? Which is not recommended now, right? So commercial products, actually polymeric commercial products are there. We can divide it into standard or high protein or high energy. You can see the specifications there. If the energy density is 0.9 to 1.2 kilocal per ml, we call it standard polymeric, and the protein content is usually between 15 to 20%. And we call it high protein polymeric product when the protein content is more than 20%. Total, if that product provide energy, 20%, more than 20% of the energy is from protein, we call this high protein polymeric product, right? And high energy product, if the energy density is more than 1.2 kilocal per ml, we call it high energy polymeric product, right? Do you know, can few of you name some polymeric commercial products? I'm not supposed to tell brand names here, but if somebody tells, I can say you whether it is correct or not. Polymeric products which is commonly used in your ICU setup or in the ward setup for tube feeding. Yes. Yeah, I heard Isocal, Sustacal, and Ensure, or maybe like that. Then we go to oligomeric. That is partially digested products. Protein is there as what is called semi-elemental. The component is there not as protein as peptide, right? Or fat may be there as medium chain triglyceride. Any semi-elemental product familiar to you? Yeah. Yes, only two brands are available in Sri Lanka, Peptamen and Pretipep, right? And elemental products, of course, not available in Sri Lanka. And disease specific formula, diabetic formula, many kind of diabetic formula are there, right? I'm not going to mention. And hepatic formula also there, 1 or 2 hepatic formula are there. So at the same time, renal and pulmonary formula also there. So this immune modulating means it contains immunonutrients. The surgical doctors, that ERAS guidelines are there. ERAS recommend sometimes immunonutrient in certain conditions, right? What are the immunonutrients? Glutamine, arginine, and omega-3 nucleotides. So this some products contains immunonutrient. Any immunomodulating formula, Only 2 kinds available, Impact and Immunomax, right? Right. And isolated nutrients are there. So preparation method is very important. The clear instruction is given in the product leaflet, right? You have to follow. Otherwise, people use, they add to formula. Just cow's milk. They add this. That is not recommended, right? Usually, this therapeutic formula doesn't contain cow's milk, right? Lactose free ideally, but very small amount of lactose is there. Ideally, it should be lactose free. So modes of administration of feeds, we can give it as bolus feeds or intermittent feeding or continuous or cyclic, right? So bolus feeding, of course, you can give up to 200 to 400 ml. right, over 10 to 15 minutes. Right, continuous feeding you usually give over 24 hours. So in between, you can use this intermittent feeding and cyclic feeding. Sometimes you provide, you give over certain period of time. You feeds orally during the daytime. Maybe even this tube feeding may be done during the night time as a continuous feed. So you can use a gravity or a feeding pump. If you have a feeding pump, better to use it, especially for continuous feeds, right? Usually, this continuous feeding is done through a feeding pump in a fluid restriction situation or small bowel. If you feed to the small intestine, you can use the continuous feeding through a feeding pump. What are the potential complications of enteral feeding? Right. You can divide into mechanical, gastrointestinal, pulmonary aspiration, and metabolic. Right. So, what are the mechanical complications? Irritation, infection at tube insertion site, tube migration and displacement, tube occlusion, and if you take a NG, when we were junior doctors, we used to check the position of the NG tube by putting the stethoscope over the epigastrium, isn't it? Do you practice it? Yeah, that is not recommended, right? Ideal way is radiological confirmation or do the pH test. So these are the complications of nasogastric tubes. It's a type of, and it's very important to provide the proper care to the ostomy site. Gastrointestinal complications. Now, earlier I mentioned about the mechanical complications. So these are the gastrointestinal complications: nausea, vomiting, abdominal distension, diarrhea, sometimes constipation, rarely. So always adhere to clean techniques and clean feeding bags after each feed and dispose feeding bags in 24 hours, right? So prevent pulmonary aspiration. You keep the patient in this position, elevate the head of the bed 30 to 45 degrees and consider prokinetics. What are the prokinetics? Erythromycin, metoclopramide, right? And metabolic complications: dehydration, hyperglycemia, electrolyte imbalances, and refeeding syndrome. So I'm not going to discuss about refeeding syndrome. That's a different topic. To prevent, you have to monitor electrolytes, phosphate, magnesium, calcium. Right? Usually electrolytes should be done daily, but if the patient is having refeeding risk, you have to do phosphate and magnesium uh, daily at least during the initial 3 days or 1 week. Okay. Enteral nutrition should be stopped once adequate oral intake is established. Right? Any question?
Yeah, now, so in the wards and SQs and even in ICUs, uh, uh, so we concentrate on many other things. So we give strong antibiotics, sometimes really strong antibiotics, and antifungal and an antiviral or whatever. One or two anaerobes, oxygen, bronchodilators, many things, but we often forget nutrition. And by the time patient is the ward for 6 7 days, so nutrition is gone, and we have rendered one and all kinds of things that the hospital kitchen has provided us. Well, that is what is available to us. And there's a tendency among us to think that nutrition is not important or it is the least important. and then when the patient is not breathing or trying to keep the patient from a ventilator, we are trying to figure out why is the muscle gone and why doesn't the patient have strength and things like that. Still forgetting that the nutrition factor we have ignored. Now, considering all that, now say if a patient stays in the hospital for more than 1 week than the expected discharge, how much has the family spent? Coming to see the patient 3 times a day, bringing these stuff, paying for 3 wheelers, getting into the bus, where they waste their time, all that. I think nutrition is something that we have to remember early. Now, that versus this crushing our, the kitchen stuff that is given to us, versus using a commercial milk product. I'm for going for commercial milk products because of this. And we don't like to talk about that due to ethical issues or whatever. But I think the patient's consumer, the patient's life is more ethical. And I don't know whether you can give an answer to that. So this concept of trying to squeeze whatever that we get from the kitchen versus going for a branded commercial product. Even if you forget the brand, the commercial product, yeah, everything is concentrated in a small scoop or two. Yeah, what do you have to say?
Yeah, well, sir. Now, regarding commercial products, of course, actually we practice a balance between this. When we go to see a patient, when we write a prescription, usually we write at least 2 feeds from the kitchen feeds, because all wards of ICUs get this kitchen feeds at least twice a day, this kanji or soup or something. We top up it with proteins, whey protein, to ensure the adequate protein intake. Calorie, of course, that is again uh, not optimized in this kitchen feed. So we use, that butter or coconut oil or something, or olive oil, to optimize the calorie content. To optimize the protein content, we top up with whey protein. So that's how we modify this kitchen feed as a well balanced or highly nutritious feed. And rest of the feeds, usually if we provide 8 or 7 feeds per day, we provide 2 from the kitchen feeds, other 5 feeds we provide from the commercial product, right? We write prescription as polymeric feed. So when our prescription is reached by the nutrition office, they provide the available polymeric formula. Actually, it is not milk. It's wrong to use the name milk. It's a therapeutic formula. Did I answer your question, sir?
Yeah, yeah.
Yes, Gauri.
Actually, I can add Narendra because we have developed our own recipes of blend rice kitchen diets, like composting 1 ml 1 kg diet. The thing is that 1 ml 1 kg recipes, you see potato, pumpkin, eggs, and all. We have developed blend rice feed. Thing is the tube population is like it's a very common complication we get when we are using that feed. But there are ways and means to avoid that tube clogging and tube complications. But actually, we have developed such recipes.
Yeah, that's correct, Gauri. I can remember this Maharagama, one or two of our consultants, Dr. Manoj Gamage and Dr. Jayani Tennakon, they developed a special formula, 1 kilocal per ml, with that special recipe. The problem is, my experience, when you prescribe blend rice feeds, patient will not get the adequate amount, because one thing is this preparation difficulty, other thing is because of the heavy workload of the ward staff or ICU staff, they don't provide adequate amount of, adequate frequency of feeding, right? So, but if you prescribe this therapeutic formula, definitely that patient will get, if you prescribe 8 feeds, at least patient will get 6 feeds. Thank you very much.
Thank you very much, sir, for that highly informative talk. Next, we have a talk centered on parenteral nutrition, which will be delivered by Dr. Yvonne Jaivira, Consultant Nutrition Physician, National Hospital, Kandy, as well as representing the faculty, Dr. Gauri Samarasekara, Consultant Nutrition Physician, Medical Research Institute, Colombo. Madam, invitation is to you.
Good morning, everybody. I'm going to talk about updates on parenteral nutrition. In clinical nutrition setting, that means in hospital setting, when we talk about nutrition, there is a hierarchy, and so we first consider whether we can improve the diet or the nutrition of the patient by oral diet or assisted feeding. Then we go for oral nutrition supplement, oral diet that we supplement with like therapeutic formula. Then it fails, like we can go for enteral nutrition as Dr. Nalinda talked. And then the last option is like I can say like parenteral nutrition, which is the most risky form of nutrition. But there are instances that we need to depend on parenteral nutrition as well. So this is the inventor of parenteral nutrition, Dr. Stanley J. So in my talk, I would like to talk about what is parenteral nutrition, when do we use that and how to use that, and calculation of just an overview of calculation of PN substrates and some complications, monitoring and new updates. So the parenteral nutrition is provision of intravenous macronutrients, that is carbohydrate, proteins and fats, and micronutrients, that is vitamins and minerals and electrolytes through intravenous route. And it is the treatment option in patients who cannot maintain adequate oral or enteral nutrition. Commonly we use these in post-surgical or critical ill patients. And these are the indications when gut is not functioning. So if in case of perforation, obstruction, ileus, and then inadequate propulsive capacity and inadequate absorptive capacity, then gut is not accessible, for example, for some anatomical reasons. And then the third indication is tube feeding is not safe or unlikely to be effective, like in ischemic bowel disease or intractable vomiting. There are several types of parenteral nutrition. We can give total parenteral nutrition. So in total parenteral nutrition, all nutrients and fluids are supplied parenterally, and basically patient is dependent on parenteral nutrition. Then the second form is supplementary parenteral nutrition. Suppose the patient is with the enteral tube, but we suspect the absorption is not adequate, or there is a gap from oral or enteral nutrition. So then we supplement parenteral nutrition uh, with parenteral nutrition. For an example, like a short gut patient, when he develops the gut mobility and all, so we give initially very liquid, very low volume liquid diets. So until he gets the fully amount, so we can supplement parenteral nutrition. Then home parenteral nutrition in case of short bowel syndrome, permanent short bowel syndrome, or bowel transplant patients for about few years. We give home parenteral nutrition, but in our settings we don't use this. In UK, we have seen home parenteral nutrition. And so then patient selection is very important, especially for supplementary parenteral nutrition. Of course, for total parenteral nutrition, if there's a perforation or ileus or there's a fistula that need gut rest, we need to give total parenteral nutrition. But in supplementary parenteral nutrition, we have to select carefully the patient, like in ICUs and all. If the patient's energy and protein intake cannot be met within 7 to 10 days of enteral nutrition, we can supplement parenteral nutrition to the enteral nutrition. So what are the contraindications? So of course we don't use parenteral nutrition if the gut is functioning, and if the PN is anticipated less than 5 days, like after 5 days we need suppose the patient is not malnourished as well, but in 5 days, like, we can fully develop the enteral nutrition or oral nutrition. We don't use parenteral nutrition. We just maintain the fluid and every electrolyte with just the normal saline, KCl added, dextrose strip, like that, not parenteral nutrition. Then inability to obtain venous access. If the venous access is not, especially central venous access, then risk of PN is more, like there are infections, other infections in the body. So the PN, if we give PN on top of any sepsis or infection, so infection can get worse. So the PN is more risky in that case rather than nutrition. Then prognosis is not that good, so that we don't use aggressive this parenteral nutrition. So, and in unstable conditions like severe trauma, acute shock, severe DM, then known hypersensitivity. In acute pancreatitis, PN is indicated only if the gut is failed or EN cannot be administered. Example in prolonged ileus, complex pancreatic failure, or abdominal compartment syndrome. So in acute pancreatitis also, we can still use enteral nutrition. So how can we deliver PN, parenteral nutrition? There are two options, like central catheters and peripheral catheters. Peripheral things is like our normal cannulas, like we use for other purposes. Then the central catheters we can divide into three categories, like short term, medium term, and long term. Short term, we can use superior vena cava, like the non-tunnel catheters. Then medium term, for about 6 weeks, like PICC lines are used. Then long term, especially for home parenteral nutrition patients, we use Portacat and Hickman line tunnel catheters, like that. These are some of the catheters. So then I'm going to talk about the substrate. So the parenteral nutrition is basically compound of the nutrients, like carbohydrate, a form of dextrose. It's coming up to 70% of the energy. Then 70%, and then amino acid solutions, there are 5%, 10%. Then there are lipid emulsion, lipofundin, 10%, 20% we have. So the evolution of the parenteral nutrition, like earlier we have soybean oil compounds, then fourth generation, like now we have MCT, fish oil, everything together once, which are good, but unfortunately in Sri Lanka we don't have these options. Then types of formulas. The first one is like multi-bottle system, which we use commonly in Sri Lanka. Then the second one is combined system. If you have seen Cabivan and TNA, like those are combined system. All nutrients are packed in a bag, and we can deliver together from one port, which is the advanced form. Then if we take the multi-bottle system, still we used in Sri Lanka that system, like we separately give through a central line, we separately give dextrose and separately give vitamins, and separately give amino acids, and then separately give lipofundin. The multi-bottle system actually has high risk of, there are several ports to enter the bacteria and all, so that there are high risk of microbial infections, and but we can tailor-made it, and it has low cost. Combined system, few line handling, there's only one port, so less risk of infection. We can actually, if we have several preparation, but not in Sri Lanka, in UK and also we have several preparation with several nutrient combinations, so we can tailor-made that one as well. So these are some of bags that we see. These are from actually from our UK centers. If the pictures are clear, then you can see that the total nitrogen, calories, everything mentioned, and the osmolality I couldn't mention. So if the osmolality of the solution is 800 to 850 to 900, we can give it through peripheral line. So the Cabivan we use here is in that form. If the osmolality is more than that, we need to use a central line. So these are some of the products. So then magnesium, potassium, calcium, and zinc, selenium, everything are included. So these are some of commercial products we used in our protein training and all. So how to calculate the parenteral nutrition according to the energy requirement and protein requirement. So first of all, we need to decide what's the nutritional status, as Dr. Nalini said, according to a tool or something like that. We decide what nutritional status that the patient is in. So according to that, we decide the calorie. And then if we take like example, 56-year-old lady following laparotomy, ideas, body weight is 50. So nutritional status BMI, we think that it is normal. So like we go for energy like 20 to 25 kilocal per kg per day. Then it comes around 1250, like. Then we have to take the volume also, how much volume that the nutrition can be provided. So according to the volume, actually if we calculate the multi-bottle system, the dextrose and all, we decide the percentage of dextrose. Then the protein, like isocysteine, of course we get 1.3. Then the protein comes around 65 grams. So our amino acids, this amino acid solution usually 10%, so that we need 650 ml per day. Then lipofundin, the lipid calculation, like if you take 10% lipofundin, we can get 41 gram of lipids, and so that 416 milliliters of lipid per day. Then we can divide it into 24 hours or maybe lipid over 20 hours and give. And then depending on the rest of the volume, we can calculate the carbohydrate needed and decide the percentage of carbohydrate, because through a central line we can give even 50% of dextrose. But in our setting with this low percentage products, it's really challenging to provide parenteral nutrition for patients with patients who are very small, like pediatric patients. Especially there's a patient in now at the moment also 63 ward, like with the fistula, the total parenteral nutrition dependent. But we have this, even we don't have this 10% amino acids or amino at this moment. So only this histamine like products, the percentage is like 3 to 5%. So like the volume, we need to have lot of volume. Like if you give 2.5 grams per kg per day, we need to give high protein for that baby, a 1-year-old baby. So we need lot of volume to provide that amount of protein. And we don't have 20% lipofani, which we use usually for kids, which has better clearance than 10%. But we don't have 20% lipofani in here at the moment, so we use 10%, so that that volume also comes a big amount, so that babies cannot be given lot of volume. So I exceeded 130 ml per kg for 1-year baby. Still I had to give 50% dextrose. So then at that moment we had to struggle with high blood sugar rising. Even the even we limit the glucose delivery to 17 grams per kg per day within the limit. Like still we get hyperglycemia, and also that's the challenge that we come across when we practice with these products. I have to mention that one. Sorry. So then not only these macronutrients, like I told about dextrose, lipids and proteins, now we need to add minerals and micronutrients as well. So these are the requirements: potassium 1 to 2 millimoles, sodium same, and then magnesium, calcium and phosphate. Of course we don't have IV phosphate preparation in Sri Lanka, so we need to depend on like phosphate buffer solutions and all. And then apart from that, we need to deliver sorry okay, we need to deliver micronutrients as well, like vitamins and all. Then these are the available products in Sri Lanka. If you can say Peri one, this is the normal Cabi one we use in Sri Lanka. The thing is, it has 1440 volume, only 1000 kilocalories are provided, so it's really not enough for a adult as well. And the protein amount, you can see it's 35 grams, so it's the protein is also less, so that we can't depend on these products as per total parental nutrition. And it doesn't have vitamin and trace elements as well. There are electrolytes, but the amounts are very low, like potassium only 8 millimoles, which is around 1/5 of the daily requirement. So you need to add, if the patient is on Cabivan, you need to add extra potassium and this magnesium on and off replacement, and calcium also. So then these are the complications of parenteral nutrition. That we can divide it infective and metabolic. Infective like local infection, and then the most risky form is catheter related bloodstream infection. Then metabolic complications: hyperglycemia, hypoglycemia and hypertriglyceridemia and liver steatosis, especially in children. And and then liver diseases, and then metabolic bone disease. Then few words about complication like refeeding syndrome. It's actually potentially fatal shift in fluids and electrolyte that may occur in malnourished patient receiving artificial nutrition or artificial refeeding. It is common to enteral and parenteral both. And hallmark of this refeeding syndrome is hypophosphatemia. You can identify it by hypophosphatemia, hypokalemia, like those features. And then how to manage this one? So we need to introduce nutrition very slowly over a few days, and we need to cover it with thiamine high doses, and also fluid also to be increased, because they have usually edema, and fluid also to be increased slowly over with monitoring. And we need to supplement, especially phosphate, magnesium, and potassium, and monitor them very frequently. Then the other complication is the most dangerous complication is catheter-related bloodstream infection. So it is we have seen lots of complications when we are doing foreign training because they are usually on home parental nutrition. So the prevention is like we need to use single lumen tunnel catheters, so they are less risk of catheter related bloodstream infection, and we need to adhere to central venous catheter care bundle, aseptic technique and all. Then appropriate insertion and line care is really important. Then the monitoring of parenteral nutrition, nutritional monitoring, and there should be a clinical and metabolic monitoring. Nutritional monitoring, so we need to monitor whether the correct amount of nutrients are provided and whether we reaching the goal and what is the body weight or the mid upper arm circumference if it's in setting of we can't measure the weight. And then clinical and metabolic features like glucose and electrolytes and the other triglycerides and all, or liver functions and renal functions at least weekly. So the micronutrient requirements that should be in parenteral nutrition are these, but unfortunately we don't have IV micronutrients, whole micronutrients to deliver these things. We have polybion, only B vitamins. So of course long-term parenteral nutrition patients won't get zinc, selenium, those nutrients when we deliver in Sri Lankan settings. It's a drawback here. Some new updates for critically ill patients, like as for parenteral nutrition, like we need to at least wait until 7 days to start parenteral nutrition because of their risk of these infections and these things. That's all. It's a very short overview, and so if you have any questions, you can. And Dr. Gauri also can facilitate.
Now, patients with severe metabolic derangement in the ICU, severe acidosis, frequent acid phase changes, multiple electrolyte imbalances on sepsis and things like that. Now, that kind of serious metabolic derangement, presence of that kind of serious metabolic derangements, so does that mean that we have to hold time nutrition?
Yes, a better hold, and then try with correcting those metabolic derangement, and then to start. Otherwise, the complications would be more.
The metabolic acidosis is a contraindication.
UK, patients with severe metabolic acidosis, they have bespoke bags, that means the compound parenteral nutrition, that they remove sodium citrate or acetate form and they incorporate more bicarbonate into it. But here we don't have bespoke bags, that compound tailor-made bags. So I think it's better to avoid, and especially we don't have small lipids in our country. So I think it's better.
Especially in renal patients also with high potassium and electrolyte imbalances, like in UK we give removing all electrolytes and just calories and proteins and lipids. So then we don't have facilities like as Dr. Gaudi said, so that if we really pump but of course in combined system, like we don't give electrolytes, and also that could be delivering that amount would be okay. So, but like Cabivan and all, they have included some electrolytes and all. So, and they are not tailor-made, also we can't make it. So that I think better to go.
So in UK, that adjustment is done by hospital pharmacists.
Pharmacist, PN specialist pharmacist are there. Thank you so much.
Questions in the chat box, I guess.
How to get the integral question and absolute control. Please,
This is for different people, I guess.
yeah, we'll see this is
This is one, yeah.
there's a question in chat box. Should we add potassium or sodium whenever we give cabivan? Yeah, we can monitor, and if it is for short term, like for short term ideas, we give cabivan and all, so we can monitor potassium. But still, I think if the patient is not taking anything orally, he needs a 1 to at least 1 millimoles per kg daily requirement. So cabivan only contains 8 millimoles, so I think better to add at least 20 millimoles KCl to the cabivan itself, or through another peripheral cannula.
Yeah, when I see the previous question that regarding enteral nutrition, something regarding intravenous fistula.
They ask it's a absolute contraindication for.
In intracutaneous fistula, if you can insert a tube, distal end of the tube can be placed distal to the fistula orifice, then of course you can do enteral feed.
That's the question. High output intracutaneous fistula.
There's a question. Can you prescribe a BLC with normal food only, or does it always need? Yeah, so if you go for a BLC, it has to be with meal replacements, or else so you can do at least 2 meal replacements and then maybe 1 meal with regular food. Because the thing is, like, otherwise you won't meet the necessary nutrients. Then the next question is plate method. We can have pulses instead of animal origin food. What is that extra energy? It's not a big concern actually. So now pulses, there are, of course, they have some carbohydrates, but the way you prepare and everything, they will be low fat. So the calories, I don't think it's a big issue. And so there are a lot of misconceptions regarding pulses. So people say that if you eat chickpeas, there is kadala, it has too much starch and all that. But all myths. So even for a person with diabetes, for a breakfast, I think pulses are one of the best foods you can have. So it's not a problem.
Thank you very much, madam, for that educating topic. So now we shall have a brief tea break for 10 minutes before we resume the next session. For the participants, tea is arranged in the adjacent lecture hall, and for the delegates and the consultants, tea is arranged in the opposite conference room. So we shall meet again in 10 minutes time. Thank you.
මේක තියෙනවා මේක තියෙනවා you have the
laser points
තියෙනවා fantastic and slide change එකක් තියෙනවා
sir මේකේ යන්න පුළුවන් මේක කනෙක්ට් කරලා තියන්න sir
ඔබ නරේසි
හොඳයි
just the file should be there just which one, sir? assessment. Yeah. Can I just
PDF තිබුණා.
Good morning, everyone. Sorry for not being able to attend the meeting physically. In the next 20 to 20.
Hello. Huh? දිනමිත්සක ප්ලේ වෙන්නේ. මම කට්ලානේ. මේ මයික් ගෑනනේ. මයික් ගෑනනේ මේකේ. දැන් ස්ටක් කරලා මේ ඉමේජ් එක දන්නේ අප්පා මේ රත්තලා ඉන්නේ කාල් හිල් කරන ඇස්සේ. අනේ මම තියන්නම්කෝ.
Good morning, everyone. Sorry for not being able to attend the meeting physically. In the next, nutrition in chronic liver disease, and and the bird. uh, The con- Good morning, everyone. Sorry for not being able to attend the meeting physically. In the next 20 to 25 minutes, I'll be discussing. Good morning, everyone. Sorry for not being able to attend. Main focus will be upon briefly touch upon the NAFLD and nutrition as well. And we cannot talk about, we can't ignore the uh, physical exercises when we talk about nutrition in liver disease. Good morning, everyone.
slideshow ගියා සේව් කරනකොට දෙකෝනේ ඒ මොකද මම කරන්නේ සර්වරුත් නෑ නිසා කවලද විදියට මම ඔක වීඩියෝ එකක් රෙකෝඩ් කරලා යන්නේ ඈ අර යනවා සවුන්ඩ් එක දැන් මේ හැම ස්ලයිඩ් එකකම සවුන්ඩ් එකක් දාලා දෙන්නේ රයිට් මේ ප්ලේ එක මේ ස්ලයිඩ් ෂෝ එකෙන් ප්ලේ වෙන්නේ
Good morning, everyone. Sorry for not being able to attend the meeting physically. In the next 20 to 25 minutes, nutrition in chronic liver disease, nutrition in chronic.
යනවා ෂේප් ඒක මේ ප්‍රෙස් එකේ තියෙන ඒක ඔටෝමැටිකලි යනවා ඒ ෂේප් එක ඔටෝමැටිකලි ඇයිද කවුරුද තියෙන්නේ ඉන්න වෙනවා අර මැඩම් ඉන්නේ පිටු කොයි කම්පැනි එකේ ඉන්නට කියනවා වතුර නැහැ කියලා වතුර නෑ post this again මොකද නෑ එන්නේ ඔක්කොම මේ කියන ඇතුලේ මේ තියෙදි ගහලා නේ මේක වෙනවනේ ඔය මොයිස් කරලා දෙන්නේ ඕනේ ශාරණනේ අපේ ශාරණනේ නෑ මොයිස් කරලා ශා කරේ නේද අර ඊළඟට කාලෙත් තියෙන්නේ දැන් චූස් එකේ තමයි දෙයක් තුනක් ඉවරයි නෑ නිවෙසට කලින් ඒක ශනිකව සිටිස් මාරනවා. ඔව් තියුනේ දැනට. නේ සවුන්ඩ් දාමුනේ. දන්නවද? අරගේ ගියේ නැත්තම් නේ. ෂෙයා දාමු. මේක ඕනේ නැහනේ.
Optimize for video එක දාන්න
ඒක තරකයි නේද නෑ.
නෑ ඕන්න ඒක දාන්න ඕන
හරි ෂෙයා කරන්න කියන්නේ.
assessment of truth එකද මේක දින ඩ්‍රෙස් එක නෙවෙයි අර පොලිස්
දිනසේ අන්තිමට
මේ ඩිස්ප්ලේ එක හොඳයි
zoom එක දෙක වෙනවා.
ඔව් ඒක හොඳයි
left right එක.
මම දාන්නකො මේ ඩුප්ලිකේට් එක ලොකු ස්ක්‍රීන් ඔබ දිසි ලස්සනයි මොකද ප්‍රිපරේෂන් ඕවර් මේක
zoom
zoom එකට දිගට
ඒකට දෙන්නේ සර්වර් ටයිම් එක මේක මේකට තන කර දෙන්න.
Ladies and gentlemen, we shall now resume the program with the third session for the day, which will be on pediatric nutrition. The speaker for this session is Professor Pujitha Wickramasinghe, who is a senior professor in pediatrics attached to the University of Colombo and an honorary consultant pediatrician at Lane Ridgeway Hospital, Colombo. His talk is titled Growth Assessment in Children and Timely Interventions. Sir, I warmly invite you to the stage.
Good morning, everybody. So, after a nice session in the morning, I would be taking you a little bit of different level or different state from hospital nutrition, going little bit out. But of course, you can't say this is not hospital nutrition, but more of a field work as well as there. So, growth is a physical development of the body, and the period from birth to 2 years of life is a critical window of growth. Now, when you consider birth, most of us think that the day the child comes out into the labor room is the day of birth. It is actually not biological, it is not the day of birth. It is the day of conception that really should be taken as the day of birth. But that is where life begins. The heart begins to tick, the nervous system begins to function. By about 20 weeks, the embryo or the fetus is able to feel, smell as well as taste. All that is functioning. So this 1000 days from the day of conception to the completion of 2 years is a critical window as per the information what we have today. So growth monitoring is one of the outcomes of this whole process, which we will be measuring and trying to find out what is the best optimum way a child should be growing. So what is meant by growth is actually physical growth I am discussing here, not the brain development and acquisition of new skills. So in the physical growth, people grow. And as what happens is actually the composition of the body changes. So if you go on very broad terms, we divide the body into two major components, the fat and the fat-free mass. Whereas the fat-free mass, of course, consists of many other parts like the muscles and the bones. So you can see that there are a lot of changes that takes place in these compartments independently to one another, which ultimately results in an outward appearance of the increase in the growth. So you can see that at different ages, the velocity, what I am discussing here is mainly the linear growth, because that is one which ultimately grows and determines our ultimate stature, because that's the main rate limiting growth factor in the body. Weight, of course, we can achieve even 200 kilograms, but usually we stop around 170, 190 centimeters in length, depending on the genetics and other components. So at birth, intrauterine life has a very rapid growth spurt, especially in the third trimester, and then it continues during the first year of life, and then gradually comes down and settles to about 6 centimeters till they attain puberty. So after that, of course, there will be the last growth spurt that occurs in life. So there, if you can see that there it will be divided into three main phases: infancy and early childhood up to about 3 years, mainly nutrition driven, and then afterwards it's growth hormone driven till you come to the pubertal stage where it is mostly sex hormone dependent. But these are not the exclusive important only component. Nutrition always plays, because that's where the fuel and the raw material that required for the growth is being provided. So you can see the distance chart. So when we are looking at the growth measurement, we can measure it in two ways. As you saw that I showed you how the velocity, the rate of growth changes. So it comes down gradually, and that means at a particular time period, usually per year, at different stages of life, people keep on growing at different rates. So this is continuing from what they achieve at birth, coming down to about 2-3 years of life, then plateauing, falling further little, and then of course having the last peak of growth during life. So all this will be accumulated every year, and you can see how much they have grown over the period of life. So that is where the distance chart comes. So if you turn back at this point and see how long they have come, weight wise, length wise, BMI or whatever parameter. But here it is per a unit time how much they have grown in that particular parameter. So usually we take the length or the height, but of course you can take it even for weight or BMI if the measurements are done and recorded. Now another section that requires a little bit more beyond the nutrition is the upper segment, lower segment. Just for completion's sake, I am putting it here. It's basically at the level of the upper level of the symphysis pubis that we take. It is not the umbilicus. It is the symphysis pubis is where the division takes place for the upper segment, lower segment. So lower segment growth is mainly the limb growth. Upper segment growth is mainly the trunk growth that we will be taking, and different ages there will be different values, as well as different disease conditions will have different values. So during prepubertal it's mainly the limb, then pubertal you get the trunk. So in puberty you get the size, shape, and mainly a distinct body composition difference between the males and females occur, where the females accrete more fat, whereas the males get more bone and muscles. And then so the different, it's actually evolutionary pathway that is for the hunter, who is the male, whereas the gatherer and the rearing of the children, for that as deposition of food and all or energy, you get the female body contour and composition. So these are all have, so that's why if there is nutritionally sound, the female would enter into menarche early, because they have to sustain the life of the species. That's why obese children tend to attain age at an early stage. So if you take 100% of the individual's height as 100% and looks at different proportions, you can see how it evolves over a period of time. And then because of this, what the practical implication is, you can't have a single universal cutoff for any of these parameters. It changes with life. So that is, although in the morning first lecture Sudhira was showing that there are static cutoff values for adults, in certain cases for the pediatric population you can't use it. So that's why we have height charts, BMI charts, waist circumference charts, like that. Depending on the age they change, and you have to make the reference at that point. So the peak height velocity in adolescent is about 10 centimeters. So what we have to make sure is we have to try to achieve this maximum, because this is the last window, and usually the body contour is proportionate. So if we try to achieve this, especially I am emphasizing for the females, because we are talking about reducing low birth weight, but we can't reduce low birth weight if we continue to have a low small mother who is 145, 150, 160, 155 centimeters. So this is the last time window of opportunity that we should not be missing, and we should try to get this. So for this, of course, the maximum thing is the nutrition as well as the physical activity have to be encouraged and looked and supervised and enforced. So then ultimately a girl will get the maximum. So the problem is again when a girl attains menarche or achieves menarche, the height velocity is almost has completed. So that is the thing. So we have to spot early breast development, which is the initial stage of puberty, and at that point itself or around 10 years onwards we should focus on the girl child especially. Not I'm saying that the boy child should be neglected, but even for them of course. So if they can achieve 1 or 2 centimeters extra, that may matter a lot for them in their life, especially if they are first trying to pursue a job which will be recruited based on their height as well as it will automatically give them the personality, which will automatically give them the confidence, which will ultimately end up in a good productive individual at the end of the day. So those are the last window from our point, from the nutrition point, we have to make sure that we achieve. So assessment of growth is now, so we try to get the best optimum growth, because when we was, or even before we were students probably, sky was the limit for upper limit. Anybody can grow with weight, height, everything. But today we have seen that we have to grow within a certain narrow range, and it should not be less, not be more. So for that we have to make sure that the visual appearance is not the thing, but scientific evaluation is the most important thing when it comes to growth. So we have to evaluate, or we have to assess, and then we have to evaluate it. So there are so many parameters, but of course we are much more familiar with height, weight, and then of course waist circumference is also gaining importance, as Sudhir highlighted in the morning, because that is one of the main key metabolic risk factors that the population is developing today. So that is, so these three are the ones, but others of course at different stages give different values. So these are the standard ones, but of course always remember that the spring balance is not a very good one, but of course if we can go for this beam balance, that's the best. And the key is also to validate or to make sure that the measurements are quite correct and the instruments are working properly. Then of course the length, we have to make sure that you have positioned the individual properly, where you don't need much of sophisticated equipment. Actually, if you position them with the heel, back of calves, buttocks, back of chest, as well as occiput into the vertical line, at least this may not be always possible, but definitely others, and you keep the head in the Frankfurt plane. So Frankfurt plane is the low orbital margin to the external auditory meters placed perpendicular to the long axis. So it is otherwise this range going from the lower orbital margin to the external auditory meters and placing them. Because you may come across that at certain points people make 3 measurements and take the mean or various things. But I of course don't believe in that. I believe if you do a measurement, you do it properly once and for all, that should be enough. Because you take 3 measurements, one will be 2 or 3 centimeters away, what are you going to do? That may be the ultimately correct one also. So I think when we do something, we should do properly, and once and for all we should have the confidence if we have done. So the same thing can be done when you are doing the length, where you keep the individual horizontally and then the Frankfurt plane again looking straight up on a, that will be in a vertical plane in that case. In mid upper arm circumference, for completion's sake, it is taken from the acromion and the olecranon. When the elbow is flexed at 90 degrees, you get the midpoint. Then you let the hand relax, and then you get the mid place measured. So more than 12.5 centimeters is considered a reasonable measure, especially for 1 to 5. But of course, people are trying to evaluate for various ages and various physiological states, especially in pregnancy. Also, people are working on this. So these are some of the quick things. So then skin fold thickness, that is actually a double skin fold of skin as well as a subcutaneous fat. So that will give an idea about the deposition of subcutaneous fat, which is an indirect measure of the stores of energy stores in the body. And of course it will give a little bit of more. There are even equations where you can calculate the total body fat. But of course, it's a little bit of difficult, especially in obese individuals. It's not that easy to perform. But of course, it in a not in a screening way, but of course in a little bit of advanced assessment, you can use that also. Then OFC. So then the waist circumference, where you keep the person resting, and then you take the mid axial line, you go down in the lower costal margin, and in the mid axial line you go to the highest point in the iliac crest and get the midpoint. It is not the level of the umbilicus, because umbilicus is a marker in the skin. It is not a bony prominence, it's not a complete. Depending on the sagginess of the anterior abdominal wall, it can get fluctuated. So you have to go by the the bony landmarks, and then get the midpoint of that and draw a horizontal line. And in usually mid inspiration, people say, or you can take it at the end of at the beginning of inspiration or end of expiration, you can take the measurement. So once you have taken the measurements, then of course you have to see whether these are appropriate, whether these are not appropriate, whatever it is. So you will do the evaluation. So for the evaluation, of course, rather than taking the raw value, you can use certain indices. Now the body mass index, which you are quite familiar with, is one. Then of course the other thing is taking the waist circumference to height index. So then of course we don't have to use very much of a chart here, because this comes as a ratio, because we know waist circumference as well as height also changes. But body mass index, of course, we have to use the chart, because with age that changes as well as with the sex. But waist circumference to height ratio is more or less a static ratio, depending, whatever the age, and a prudent value is actually 50%. And we have proven this, of course, metabolically. 0.45 would give metabolic syndrome, but 0.5 would give the reasonable metabolic risk. And this can be used, and even in school textbooks of health sciences, we have included this. So grade 6 health textbook contains this measurement of waist circumference and validating, and that is a very, very simple, very effective way of assessing yourself or the individuals for metabolic risk as well as risk for obesity. Then the span, of course, you all know that you have to keep it on horizontal line, the abduction of the two shoulders, and measure from middle fingertip to the other middle fingertip, and that is more or less equal to the height of the individual. So if it is any deviation, it could be a disease condition. And the practical other thing is that this will be sometimes helpful, especially people who have been amputees or totally in the bed and in difficult states. Of course, you can get a reasonable good idea about the height of the individual. So should determine whether the normal or abnormal growth is occurring. So we have to use cutoff value set, but what is being done is comparing with the population parameter. So we can't have individual values, but we have a population level charts, and then we compare with them. Now I told you earlier also this. So then what we have here is what is available in Sri Lanka, and you can see we are using the WHO 2006 reference, which is came out of a multi-center growth study. And then for the older children, we have height charts as well as BMI, but this is of course again 1975 US data, which has been re-looked at it and done with little bit of more statistical verification. So but the WHO have been given these charts for countries which do not have their own charts. So once we have plotted them, so we will be having charts like this. And anybody wants to make a comment to the question? What do you like to comment about A and B? Or do you can comment, cannot comment? What? Why not? You don't know what has happened, right? Although A is in a area which we designate as normal, B is in an area which we think it is not normal. When we look at the trajectories, you can see what has happened. So looking at a single value for this guy is unfair, because this one has the potential to be somewhere here, and there had been something. Then of course when this fellow falls here only, if we begin to interview, it's too late. So you have to pick these ones. So for that, what is most important in pediatric practice growth monitoring is to serially document them, because most of the instances weights are measured either in the OPD, in the vaccination clinics, or even when they come for consultation. But unfortunately, most of them do not get recorded. So if this recording does not happen, you and I will not be able to take some action. So it's very important. So now this guy, of course, he had started small and he had kept on going nicely. So if you try to get this fellow up, he may end up in diabetic clinic in about 10-15 years time, or even earlier than that, at the rate what we see in the community. So it is important to see the whole growth trajectory rather than taking a single point and trying to interpret, because that will be totally wrong in one sense and unfair by the individual. So usually if you look the trajectories of growth, so they can have an initial maybe a catching up, but you have to be careful this catch up, which I will come to a little later. Then of course they will keep on going, then they will begin to deviate, which we call as faltering. If we are smart to pick up at this point, then it is the easiest to rectify that. But if we go if that goes unnoticed, they will be flattening. Then if still, then of course what will happen, there will be a drop, and then bringing him up here is a little bit of tough thing. And so then of course we will find out what is the reason. So this, if we pick as early as possible, it would be the best thing to rectify. So that is what is actually meant by the real timely intervention. So if you monitoring growth is not the only thing, you have to intervene, and you have to intervene at the right time. If you don't do that, then of course it's just like any other illness, because as much as Sudhira said obesity is an illness, it's also within quotes a form of illness or form of risk factor. So you have to rectify, you have to correct it at the earliest possible time in order to get the best outcome of that individual. So if you look at this individual or two individuals, so one person is, now both of them are growing. So is it enough using the weight chart is the next thing. Now you can see the blue one, what has happened here is his length is this much, and then this individual is this much. Now the two weight lines are growing very nicely, so we don't have to, based on the previous slide I told you where they are growing nicely. Are we happy about this? Then, but of course we definitely have to make sure whether this individual matches or gets the optimum. I told you initially that proportionately the individual keeps on growing. So as much as he gains weight, because weight is a composite outcome of the growth of the individual, but we also have to make sure that the height is the rate limiting thing, and we have to get the maximum out of that. So in order to achieve the maximum height, we have to plot and see, and you can see where does this person is and where does this individual height is. So this one has grown very well in the height length, this one has been low, as much as matching his weight trajectory. So here it has been in -1, where in -2, and when you go there you can see the height potential is much higher. It has been around +1, and then this person is matching with his weight trajectory, and you can see at the end of the day the blue person is actually undernourished, whereas the red person is actually, or the purple, the yellow one is within normal. So in other words, although we see that the individual has a reasonable good weight, but he had grown in height, and when you look at the weight for length or weight for height, he's behind. And then the ultimate result is, if we don't correct that, he will begin to lose his length also. So from a median or +1, he will go down to median, he will come down to -1. So this one who has a good potential to become 175 centimeters may ultimately end up with about 160, 165 centimeters. So who is to be responsible? So that is where we have to look into this. So that's why what I want to emphasize is, weight alone is not enough. Periodically you have to put them onto the length as well as weight for length and see whether the individual. You may not be able to 100% achieve a median weight for length, but at least something between -1 to +1 would be a nice target to achieve, because you are concentrated the fellow to the optimum matching weight for length. So then if this begins to go up, of course, then you have to make sure that you are not overfeeding the individual. So that is the important. So out of the 3 charts, most important is actually this, because that this will detect undernutrition as well as overnutrition. So you have to, so periodical. Now length measurements, of course, first year you can do 3 monthly, you will get a reasonable detectable change, but afterwards at least 6 monthly you can do it, and then you can pick up this deviation and rectify. Because as much as I am talking downward deviation, the upward deviation is also similarly important, because if you don't pull them down timely, then of course they will again end up with obesity, which is very, very difficult again to bring down to a lower level. Now the other problem what we face today in the field is this 6 months of exclusive breastfeeding. Don't get carried away that I am an opponent of 6 months of breastfeeding. But what we have to do is we have to be very careful from 4 months onwards, because a reasonable, I won't say majority, a reasonable number of children begin to fault at that point. And many field workers, grassroots level field workers, think till 6 months child is not ready to receive food or solid meals. That is totally wrong, because even in the guideline, when it was written, it was clearly said, if the mother is not available for feeding, if the mother is a working mother, or if there is growth faltering, we have to start complementary feeding at 4 months of age. So if we, now what has happened in this individual, you can see where somewhere here is the 4 months, around 4 months, and then it has been little bit of deviation. And at this point, when this keeps on, if you keep on till 6 months, then of course pulling up the child is not, because for this particular period of time, mother had nicely fed the baby. So there can't be a learning issue either from the mother's point or the baby's point. They have been latched nicely, they have been positioned nicely, attached quite nicely, and sucked and grown nicely. So this is, if there had not been a severe illness, the main reason is the calorie, the provision of calories by mother's milk is, what is provided is not enough for the growth of the individual. So then of course, without any delay, immediately you have to put them on complementary feeds. Otherwise that will be ending up in a disaster. So growth will take its own inherent curve, but of course we have to make sure what is this inherent curve. As I said, you have to determine it by the weight for length chart. Make sure that it is within at least -1 to +1 range, and then transform it into the weight chart, because weight is much more easy. You can do it every month, easy to measure, easy changes will be reflected very fast, and you can give a good guidance, and that is one of the earliest things to deviate, because you will not see a length change or length plateauing, but of course definitely the weight. So you can intervene very quickly. But there could be drops, as I showed you earlier. It may be due to infection or maybe due to famine. Then of course you have to correct it and push them up. Then of course catch-up growth. Quickly if I go through that, maybe I have understood rise of the fast growth on later disease and promotion of catch-up growth for term small for gestational age infants is no longer recommended. Because if there is a term baby who is 2.4 or something or 2.5, we don't try to push them up unnecessarily, unless the baby was born to a mother who had a placental problem or who had a uterine problem like a biconvex uterus did not allow the child to grow. Unless those things are there, But if the child was born small, that means there had been some insult, some potential loss, and the child is growing at a small rate. So they should not be overfed in those instances. And we know the first 1,000 days where the fetal origin of adult diseases brought up by Professor David Barker alone was not explaining most of the things, especially when it comes to Asian continent in Asian region. And then Alan Lucas and Atul Segal came up with the postnatal growth acceleration hypothesis, where if the individual is growing at a very fast rate in the first 1 year or 2 years of life, then of course they are at a much more risk. And we have our own even data to show that at 1 year of growth, accelerated growth at 1 year has shown at 11th to 10 years that they have large amounts of fat compared to those who did not have accelerated growth. So we know that the fat is the prime problem which is leading to obesity, and by definition also having excess fat is the definition of obesity. So that means we are pushing them. So we have to be very careful, and crossing upwards centiles should be looked after very, very carefully. And not only that, even in another research, 5 to 15 years, we have shown how insulin markers have changed. Not only insulin markers, if you go for this to this paper, you will see even other parameters like lipid profile, hypertension, all those are there. The ones who had a rapid growth in the initial phase, or if they have been low birth weight and they have been growing rapidly. So if the child is 2.5 kilos, don't expect him to be a large size person later in life, because it is a time bomb. It is ticking. One day it will burst. So you have to make sure very, very carefully that they are within the lower part of the BMI charts, not in the higher parts of the BMI charts, especially when it comes to the low birth weight individual. So it is not only the low birth weight. If you leave the low birth weight ones to be small, then they are metabolically protected, rather than trying to make them big people, which they are metabolically very, very unhealthy. So coming from that, now which was the catch-up growth, you have to again see whether, now you can see this one is catching up and crossing so many centiles, whereas this one is just crossing one centile. So whether this one is obese, whether this one is obese, you have to see where. So you have to match with the height. And if you plot again, you would see the two lines. Here you can see the blue one keeps on going on the same centile line, whereas the one who was catching up or crossing in the weight was also crossing the length. So ultimately his weight for length was matching with each other, whereas B was already at a higher level. So what you have to do is, that's why I say I just wanted to highlight for both components, whether it's undernutrition, whether it's overnutrition, weight for length chart is very, very important. So then of course touchdown phenomena is also there. This again sometimes we get a little bit wrong, especially any child who is born more than 3.5 kilos weight in this country. In my experience, it's actually a obese child, because they So what happens is that if you inquire any child born with a 3.5 kilo birth weight or more, either the mother had gestational diabetes, or there is a strong family history from mother's side, there is a diabetic history. So that means the mother would have had subtle diabetes or hypoglycemia. We don't call it gestational diabetes, actually it is hypoglycemia of pregnancy, because they have more glucose being supplied to the individual. So the baby keeps on growing, but afterwards the baby can't sustain that. So if those ones who have a small drop, don't think that is purely due to the mother's inadequate milk supply, because sometimes this will happen is ultimately thinking that people will push them in to take formula milk, thinking that the mother's milk supply is not enough. So you have to carefully monitor them and see whether within about 2 to 3 weeks time they will settle into their original trajectory of growth, and then you follow them up without being in a hurry to add them onto the formula milk, because invariably you are pushing them into a wrong trajectory. It just got stuck or something. So, quick word about the bone age. Of course, you all know that you take the X-ray, which will show the maturity of the individuals. So, usually bone age matches the height age, because some people will grow at a higher rate and the bone age will match them. But of course, there will be conditions where the bone age is retarded. So, what you do is, on the same height chart, you will try to mark the bone age. Now, the height age, the chronological age is here, but for these individuals, the bone age is here. So if the child is around 9 years, you can see the bone age is 6.5. So you will try to match it with here, and you can see the bone age has been matching with the height age or the median height of the individuals, more or less. So that way you can get a good idea about the maturity of the individual's skeletal system, as well as those who are having higher height will also have a advanced bone age, and especially these conditions are important, especially if they are having any endocrine disorders. So few case scenarios which I have picked up from patients. So this is a 6-year-old child who came with 13 kilos and 105 centimeter height at 3.5 years of age, and you can see exclusively breastfed till 6 months despite weight faltering at 4 months. So you can see at this point now the child had begun to falter weight, exactly 3, and at 4 months you can see that there had been a faltering. It was not rectified and then went on. Only at 6 months the child was introduced for complementary food, and you can see what has ended up, where the child is in both the weight charts. You can see how bad they are, because he started with a good -1 SD length, and then similarly this is a point where you can see it kept on faltering, and then even at 5 months this child was not started on complementary food. So unless you start here, actually it should have been intervened much earlier than this, because these points have been going on without looking why it was happening and referring to the next level, but keep on telling to give breastfeeds. But of course ultimately you can see it is not going in the correct direction, and this one actually according to the birth weight should be somewhere around 6.5 or plus kilograms. Similarly, you can see a typical what I showed you earlier, where there had been faltering and then flattening, and now there is a drop. So this cannot be picked up at this point. It should have been seen at this time and try to rectify, which never happened. So then on the other hand, this is going up, but of course you can see this individual went on and stabilized here, and then now unnecessary giving reportion. Now this child had been going on nicely, yes, and I think later on he was introduced to reportion also. Now this is again another thing which is been a highly abused component available in the, ultimately the needy ones do not get it. So that's why I have been fighting for a long period of time with the reportion circular, and especially not to give for pregnant mothers who are having a normal body BMI or a high BMI. That is just pushing them up and up. And here in this case also, there was no indication to give reportion to this child, and it was given, and you can see what has happened ultimately, right? So that is one thing. So here again, at different points, this child was seen, but till 6 months, that one was not started on complementary food. So this is something that is happening in this field, which I want you all to address that, and you have to critically look at the chart whenever you see a child, and see, especially for 6-month children, there is nothing to be scared of starting complementary feed. Even some children you can start even at 3.5 months, depending on the maturity. Because if the extrusion reflex is not there, if the child is accepting the food, then of course you can properly mashed food you can give it. Then the problem is that most of the time they are given calorie poor or calorie less dense food. So that has to be stopped, and you have to go for a good food item which has a much more higher calorie dense value than mother's milk. Mother's milk is somewhere around 65 to 75 maximum, usually around 60 to 70. So it has to be at least 100 kilocalories. If you prepare a proper complementary food, of course, definitely it will touch around 120, 130 kilocalories. So similarly, this one was not started. Then I started him on complementary feeds, and you can see change of the direction of the growth. So these are some of the things which I wanted to share with you. Thank you. Any questions? Krish. You can shout.
Thank you very much, sir, for the excellent lecture. I just wanted to ask you about the introduction of supplementary foods. Some of the patients who I have seen in the clinic in recent months, they have started introducing millet and oats as some of the supplementary feeding options, which we have not should
Yeah. Now, I think that is a long topic to be discussed, and I, of course, totally discourage them. Why I do discourage them is a lot of research to show that feeding children with these therapeutic extraneous food items alone has not improved most of the growth. Why? Because the gut microbiome plays a hell of a big role. Today, it is a separate subject itself. And what will help the gut microbiome is your natural food items. There may be genetic selection, there may be a lot of things which we don't know. So I, of course, totally discourage that, and I, of course, tell them for a snack in older child, because one of the biggest passion is to give oats. And sometimes, if it is a known person, I will say we are not Americans. Obviously, not for any ill this thing, because our tummies are not American tummies. Our microbiota is not the American microbiota. When you go abroad for 2 or 3 days, when you eat a foreign food item, that does not agree with us. And you feel little bit of boberigma and you feel uncomfortable. That is mainly because the bacteria is not playing. So I don't think those are the ones that will agree. Unfortunately, I have not done research on that sector. But anecdotally, I could see that. And then translating the knowledge from other research, where I think you have to, while you are promoting the growth by providing the macro and micronutrients, you also have to look after the gut microbiome, which has a very, very big role to play in the nutrition and health of the individuals, which is now coming into light, and I think it's a very, very hot area in US and Western Europe. So I think simple answer is better not to encourage that. One thing is this is also, as well as there is enough stuff here. Yeah.
We take the nutrition synthesis after according to upper segment, lower segment.
Yeah.
Is it correct to take the sitting height as the upper segment?
No.
Sitting on this scale.
You are sitting on the ischial spines. So ischial spines are much below than the, if you take the pelvis goes like this, and you have the ischial spines. So it is actually, you are sitting on the ischial spine. So then what you call it is subischial spine leg length. You define the lower part. If you take the height, you take then the sitting height. Height minus sitting height comes as the subischial leg length. The defines. It's not the lower segment. So actually measuring the upper segment, lower segment is not that difficult, because you just bring the vertical this thing and keep it at the level value. Now you take the height like this. At that point you turn the side and bring it down, and you hold it at the level of the symphysis. Any other questions?
So you did touch about the detrimental effects of catch-up growth. I have seen some babies who are born low birth weight without overfeeding, without any specific things, while being on exclusive breastfeeding, still they catch up. So in that instance, what's your
Yeah,
advice?
that's why you have to go back to the weight for length chart. One thing is you have to see why this child was low in the birth weight. Whether the mother has a biconvex uterus, whether there was an accident to the placenta in the last trimester somewhere, and the potential which was the child was born with or inherited with has been deprived because of the lack of calories during that. Then those ones come out to the unrestricted environment. If their mother's feeding is good, they will go. But still, breastfed babies also can become obese. So where you find it out is you go back to the weight for length chart or weight for length chart, plot the length, the weight against the length, and see whether this fellow is sky high or whether this one is in. So that point you now decide, okay, you see now he's just between the median and the plus one. So that means it's a fantastic, no? So then you see in the weight chart and you advise them, okay, keep on going, but come in next month also. Then you see this fellow keeps on going on that line, whereas he has plateaued also, not plateaued, he has settled to a line on the weight for age chart. Because the weight for age chart is the easy one, no? That has to be verified whether that position in the weight for age chart is matching with his weight for length chart, where you want to keep this fellow proportionate, right? So you go back always to the weight for length, double check with that whether his weight is matching the length, because we are not measuring the body composition, right? That is a deeper topic. But for our this thing, at least if he is within the -1 to +1 in the weight for length chart, then we at least might be happy about that.
There's a question on the chat.
Sorry. Oops. Sorry, so the emergency situation related class. Well, in an emergency situation, if there are large masses, of course, we have to do the quick screening. So the MOAC is the best screening tool what we use now. But unfortunately, in this country, we don't see mass problems like that. And we have the facilities to do the weights and the heights to a great extent, even in the field. But MOAC has a place as a screening tool, plus or minus with ankle pitting edema. Then of course they have to be sent to a central place, and then you have to verify this with the heights and weight. So heights and weight will give the final diagnosis more or less, whereas MOAC will give a good screening assessment in the initial.
Sorry.
Yeah.
I don't know whether I got it correct what you said. So in growth of height, you said the highest rate of growing height is around 12 to 14.
That is the pubertal growth spurt.
Then from that onward to the place where artificial growth fusion, artificial fusion happens.
Yeah.
Although the rate is slow, net, look at the net height in the figure.
Now, what happens is at birth you have a higher growth rate, then it gradually comes down. It settles to about 4 to 6 rate, and then the velocity all of a sudden climbs up to about 10 or so, and then gradually again stops. The puberty is a window. No? Puberty is a window. In that window they will have a high rate, so that rate is also not static. All of a sudden it will not go like this, it will increase, and then the maximum and it will fall. So in the females, just before menarche they will have the peak. In boys it will be little late. Yeah. So because that the boys are taller because they have little bit more natural growth for them to occur. Because once you have the velocity, not immediately, I mean soon after velocity, epiphyseal plates begin to fuse and stop the growth, because the spurt comes with the hormonal changes, and then in that also you have a rise in velocity and fall in velocity. So then it will settles and it comes to a zero velocity later on, once the epiphyseal plates are fully fused, maybe around 18-20 years. By that time he has gained the highest maximum, finished the total length what he had gained over the period of time. Thank you.
Thank you, sir, for that wonderful and illuminating talk. We shall now move on to the fourth and final session for the day, nutrition in liver disease. The speaker for this session is Dr. Nandana Dinamitra, consultant gastroenterologist, District General Hospital, Polonnaruwa. He will be delivering his talk as a recorded video, which will now be played.
Close down. Food and assessment.
Good morning, everyone. Sorry for not being able to attend the meeting physically. In the next 20 to 25 minutes, I'll be discussing the nutrition in liver diseases. My main focus will be on cirrhosis in general, and the obese patient with cirrhosis. If time permits, I will be briefly touch upon the NAFLD and nutrition as well. And we cannot talk about, we can't ignore the physical exercises when we talk about nutrition in liver disease as well. So I'll touch upon that as well in my subsequent slides. Nutrition in chronic liver disease. Nutrition in chronic liver disease. And my talk will be focusing on malnutrition in liver cirrhosis, consequences, why malnutrition, and identifying malnutrition and nutritional management. And I'll talk about nutritional management in obese cirrhotic patients as well. And my talk will be focusing on malnutrition in liver cirrhosis, consequences, why malnutrition, and identifying malnutrition and nutritional management. And I'll talk about nutritional management in obese cirrhotic. The burden of malnutrition in liver cirrhosis. The liver has a vital metabolic role, therefore loss of function has significant nutritional consequences. The severe the liver disease, the severe the malnutrition. So, and the vice versa. And the progression is associated with the progression of the liver failure. The burden of malnutrition in liver. Can you look at this slide? Like, I'm sorry for the small print. Here, this is child score. The higher the child score, the higher the problem with malnutrition. And 1 in 3 cirrhotic has sarcopenia. The consequences of malnutrition in cirrhosis, if you look at this table, any complication is about 48 to 66% prevalent in malnourished people when compared to well-nourished cirrhotic patients. And all the complicated hepatic encephalopathy, ascites, SBP, hepatorenal syndromes are more common in malnourished cirrhotic patients. Why malnutrition? What are the causes for malnutrition in cirrhosis? One thing is inadequate provision of nutrients because they frequently present with nausea and they have loss of appetite, anorexia, and can have abdominal pain, early satiety, sometimes unpalatable diet because of our dietary restrictions, and poor dentitions and frequent hospitalizations. And socioeconomic causes can contribute for this inadequate provision of nutrients. Why malnutrition? What are the causes for malnutrition in cirrhosis? Then the other thing is abnormal substrate utilization. In cirrhotic patients, their metabolism of carbohydrate, protein, and fat are different from the normal people. So they have like decreased skeletal muscle hepatic glycogen production as well as increased gluconeogenesis. When it comes to protein, they have increased catabolism and increased use of branched chain amino acids. And the fat metabolism, they have increased lipolysis, enhanced turnover and oxidation of fatty acids. The percentage of total energy from fat, carbohydrate and protein that they used in non-cirrhotic patient for 36 hours, they can use within like 10 to 12 hours. So their metabolic rate is very high. Then the other thing is abnormal substrate utilization. In cirrhotic patients, their metabolism and they are in a kind of hypermetabolic state where they have very high energy expenditure and they use a lot of macro and micronutrients at a higher pace, at a greater pace. And if you consider this simple math, for an example, if you have a 60-year-old male who is 70 kg and his energy expenditure, the requirement if he is non-cirrhotic is about like 2067 calories, but if he is cirrhotic, his requirement will go up to 2800. Likewise in protein, if he is non-cirrhotic, it's 74 gram per day, but if he is cirrhotic, the decompensated is cirrhotic, then it goes up to 109. And they are in a kind of hypermetabolic state where how do you identify malnutrition? Malnutrition can be present in low BMI, normal BMI as well as high BMI people. Both fat mass and the fat-free mass can be depleted. Usually like female have like reduction in fat masses. The male have like fat-free muscle mass reduction. How do you identify malnutrition? So identify malnutrition. There are a few screening methods. One is like subjective global assessment of nutritional status. We call SGA, and we can have the hand grip strength as well, which is shown in this picture. And we can use the MUST, like malnutrition universal screening tool, where we can see the BMI and the weight loss within last 3 to 6 months. But we may not be able to apply MUST protocol if they have edema and ascites. So identify malnutrition. And the nutrition, when it comes to proper nutritional management, nutritional counseling alone can be successful in increasing dietary intake. And about various doses of carbohydrate used in studies from like ranging from 50 gram to 110 grams. 50 gram is the minimum amount which is needed to prevent ketogenesis and nitrogen sparing effect. And we need to supplement the patients with supplementary nutrition if they have cirrhosis. to like avoid them having losing their preserved skeletal muscle mass. It is beneficial to have like small frequent meals and try to eat something in like every 2 to 3 hours. And the nutrition, when it comes to proper nutrition, the late evening snack is beneficial and is proven to be beneficial in cirrhotic patients. The late evening snack is beneficial. What is the rationale is the increased catabolism of and reduction in content of hepatic glycogen stores. And snack content, you can have like any commercially available one like Ensure Plus or diabetic resource. And it's better to have branched chain amino acids in it. And the effect of nocturnal supplementation that will increase the total body protein as well as that will reduce the rate of liver related morbidity and mortality. And it decreases the frequency of paracentesis as well. And next we will talk about the role of nutrition in management of malnourished and sarcopenic liver cirrhotic patients. When it comes to the macronutrient requirements, they need about like 1.2 to 1.5 gram of per kg per day protein, as well as the kilocalorie about 35 kilocalories per kg per day. But if the patient is obese and cirrhotic, then we have to have high protein, like 1.5 gram per kg per day protein with hypocaloric diet. What is meant by hypocaloric diet is you give the calorie about like 500 to 800 kilocalorie below the daily needs. And next we will talk about the role of nutrition management. We were brought up in an era where if something to do with the liver, we were taught to like restrict the protein, but that is not true. Now we have enough evidence that they need more protein than the normal patients. You shouldn't restrict their protein intake. And what about zinc? And what about zinc and magnesium? They are deficient in zinc as well as in magnesium. Zinc deficiency can present with so many ways. They can have ectodermatitis, glossitis, hypogonadism, and sometimes they can have slow wound healing as well. So it's better to supplement them with 50 milligram of elemental zinc, or if you have like zinc sulfate, it's better to give 220 milligram of zinc sulfate per day. When it comes to and what about zinc? What is the role of nutrition in management of obesity in patients with liver cirrhosis? I'll talk more about this one and I'll show you the evidence as well. Obesity is at least as prevalent in people with compensated cirrhosis as it is in the general population. And patients with like cirrhosis can be the NASH, so they are generally obese. And like if you reduce their weight, like if a 5% reduction of weight, 5 to 10% reduction in weight is sufficient to reduce the progression of the chronic liver disease. What is the role of So how do we do the weight reduction in obese patients? One is lifestyle interventions, pharmacotherapy, endoscopic bariatric or metabolic therapy, we call EBMT, or surgical management or bariatric surgeries. What are the lifestyle modifications? Like there are a lot of research out there, the data out there. They say like therapeutic physical exercise program. that can improve their mortality as well as the disease free or like better quality of life after transplantation, and that will improve the 6 minutes walk test as well. And intensive lifestyle interventions programs in cirrhotic patients, like reducing the 6 minutes walk with supervised physical activity per week. It can reduce the portal hypertension as well, and that will reduce the progression of the chronic liver cell disease. As well as during that process, the decompensation is reduced, and worsening of the child score, ML score is also reduced. But look at this research, the immediate effect of exercise on portal pressure. I don't know whether you can see this one. Look at this one. Within like first few minutes, the portal pressure goes up, but then it becomes like plateau after some time. But if you do exercise for longer time, then look at this one. This the line just above the red one is like coming down. That is the portal pressure. So it comes down. Initially with exercise it can go up, but long-term exercises will have beneficial effect on portal hypertension. And look at this graph. This is the like exercise versus ammonia level. With the exercises, ammonia level goes up in liver disease patient as well as in normal patient, but the rise is more in liver disease patient. As well as that rise is more sustained in liver disease patient. It's clinical significant, we do not know yet. How much exercise should you do? Like we do not have robust data to guide us in cirrhotic patients, but we are extrapolating from normal populations the target physical activity for healthy adults, like 150 minutes of moderate aerobic activities per week, or if we are doing strength exercises, at least more than 2 days per week. What about the endurance versus resistance training? These are from like normal people. It's not from cirrhotic data, not coming from cirrhotic patients. So it increases the muscle capillary vascularity, and the strengthening exercises will markedly increase the muscle mass and muscle strength. So we recommend to have like both endurance, that is aerobic, and strengthening exercises for the cirrhotic patients. There are a few don'ts in exercises in cirrhosis. One, we shall not do heavy exercise at the start of exercise program because they can be osteoporotic, osteopenic, they can injure themselves. And exercises while alone at home, so they can have hypoglycemic attack. And exercise during fasting periods such as in Ramadan. And exercise in fasting status is not recommended. And exercise in presence of high risk varices. It's because, like as I showed you earlier in the slide, during the exercises, portal pressure can go up. That can result in disasters. So stop the beta blockers. And there are do's in exercises that everyone shall be advised to exercise, but shall be assessed for its safety before advising exercises. You have to gradually increase the quantum of exercises, and it's preferred to have aerobic and endurance exercises as I showed you in previous slides. And combine all 4 types of exercises to optimize the benefit, and must couple your nutritional advice with exercise. So ensure adequate dietary protein intake, like 1.2 to 1.5 gram per kg per day. And these are about like obese cirrhotic patients. The next option, you do the lifestyle modification, then you can arrange endoscopic bariatric or metabolic therapy. but like only studied one is a gastric restriction or intragastric balloon insertion. There are some data saying like they can lose sort of weight and it is beneficial. This is intragastric balloon shown in this picture. And the safety of metabolic and bariatric surgery, whether it is safe in cirrhotic, there is not much data available there, but out of the available data, the sleeve gastrectomy is better than Roux-en-Y gastric bypass in cirrhotic patients. The role of nutrition in management of hepatic encephalopathy in end-stage liver failure. The role of nutrition in management of hepatic encephalopathy in end-stage liver failure. If you look at this one, the nutrition and hepatic encephalopathy, if you restrict their protein, as we did about like 5-6 years back, the protein restriction does not improve hepatic encephalopathy, and rather it is detrimental. It increases the muscle breakdown. Look at this, the white one is a low protein diet, the darker one is a normal protein diet. There's no benefit. The role of nutrition in liver transplantation. The nutritional therapy in the post-transplant period enhances nitrogen balance and it lowers the viral infection rate of infections as well as a tendency to shorten the intensive care unit stays, and it reduces the cost as well. The role of nutrition in liver transplant. The general nutritional recommendation in cirrhotic patients, calorie intake about 25 to 35 kcal per kg per day. If patient is malnourished, you give like 30 to 40. Protein intake is 1 to 1.5 gram per kg per day. Maximum is about 100 gram. And it's better to have large proportion of protein from vegetable sources, but it is difficult to find vegetable sources in our country. And it is best if it is rich in branched chain amino acids. And carbohydrate intake should be 5 to 6 gram per kg per day, and not more than that. Or fat intake about 25 to 30% of calorie intake. And it's better to have small frequent meals. And look at this slide. So whoever who has cirrhosis, you need to like screen them for malnutrition and assess for frailty and sarcopenia. If both normal, you educate the patient, and at every visit, you reassess them. If they have any abnormalities, then identify the contributing factors and treat them. In summary, nutritional support can and does improve morbidity and mortality, and malnutrition should be identified and treated early, and dietary restrictions are rarely indicated. I'll rush in subsequent. In summary, nutritional support can slides. I'll just talk about briefly touch upon the NAFLD, non-alcoholic fatty liver disease. It resembles alcohol-induced fatty liver disease, except the history. They are not alcohol abusers. Slides. I'll just talk about briefly touch upon the NAFLD, non-alcoholic fatty liver disease. It resembles alcohol-induced fatty liver disease, except the history. They are not alcohol abusers. There are like few types, like simple steatosis, steatohepatitis, fibrosing steatohepatitis, and there are like few types, like simple steatosis, steatohepatitis, fibrosing steatohepatitis, and cirrhotic. There are risk factors like overweight, obesity, and central obesity. Cirrhotic. There are risk factors like overweight. And the major underlying risk factor for the development of NAFLD is the insulin resistance. So if you look at the NAFLD patient, like about 30 to 100% of them having obesity, and the prevalence of diabetes is about like 10 to 75%. and hyperlipidemia is prevalent in 20 to 92% of NAFLD patients. And the major underlying and the nutritional management of NAFLD, the treatment centers around reducing insulin resistance, dietary intervention, and increased physical activity. Even the weight loss is the modest weight loss is beneficial in this case, 5% weight loss is beneficial. We recommend weight loss is about 10%. That should be and the nutritional slow weight reduction. If we have rapid weight reduction, that can be detrimental, and that can worsen the liver function, as well as that can progress rapidly from NAFL to NASH, and it can go into liver failure as well. Slow weight reduction. If we have rapid weight reduction, that can be detrimental, and that can worsen the liver function, as well as that can progress rapidly from NAFL to NASH, and it can go into liver failure as well. So normal weight subjects, you have to give them dietary advices, healthy diet, as well as if they have high lipid and high sugar, you have to treat them. In overweight individuals with elevated aminotransferases, 10% weight reduction is beneficial. That has to be done over a period of time. It's not the rapid weight reduction. So normal weight subject modification in lifestyle, which involves weight reduction and regular exercise, are the mainstay of treatment and prevention of NAFL. Modification. Another treatment, as you all know, we give vitamin E, that is about 800 units per day, but that is only for the non-diabetic biopsy-proven patients. But in my practice, I do give non-diabetic patients who did not have biopsies. And we need to replace saturated fats with polyunsaturated fats in our diet, and omega-3 fatty acid may be beneficial. As well, there are emerging data that probiotic supplementation may be beneficial in managing NAFLD and slow the progression, and that can reverse the high AST, ALT levels. And you need to monitor them for vitamin B levels, because some of them have very low vitamin D level, then you need to supplement. And the milk thistle is said to be beneficial, and there are a lot of data regarding that. Another treatment. And few words about the herbs, as is advertised freely in social media and printed newspapers. The herbs are potent medicines, and the community is increasingly seeking out the alternative medicines, alternative therapies like easy therapies. And there are a lot of NAFL patients out there, so they are also seeking alternative therapies like herbs. And it's important to be aware that these can be harmful at times. The patients with non-liver disease, these herbs can be very toxic, so be aware of. And few words about the herb. In summary, there is no quick fix. There are no gimmicks for the consumer. And you need to control the weight, you need to increase your physical activities, and if you have diabetes, you need to control diabetes and manage lipid abnormalities. I have come to the end of my presentation. Thank you very much. I'm sorry I will not be available to answer your questions. I'm sure Dr. Timothy will clarify your questions. Thank you very much.